This is case number 18, radiograph of leg showing marked demineralization with blurring of the inner cortical margins and loss of trabeculations are characteristic. Several pseudo-fractures are seen, presenting as sclerotic transverse lines in the tibia, consistent with osteomalacia. Case No. 19. A horizontal fracture of the tibia and the fibula is present in this child with osteomalacia, rickets. Fractures of this type are called Looser's fractures and are virtually pathognomonic for osteomalacia, however, they are rarely seen. Findings of Looser's fracture reason osteomalacia. Case number 20, vitamin D-resistant rickets, X-linked hypophosphatemia. Osteopenia with multiple fractures/pseudo-fractures and anterior bowing deformity of the tibia is seen. Case number 21, vitamin D-resistant rickets, X-linked hypophosphatemia. X-ray is showing mild osteonia with bowing deformity and pseudo-fracture in the distal femur and genu varum is seen. Case number 22, radiograph of abdomen is showing increased bone density secondary to renal osteodystrophy is seen. Note also the extensive bilateral nephrocalcinosis. Findings of renal tubular acidosis.
Case number 23, frontal radiograph of both hands, subperiosteal resorption best seen along the radial margin of the proximal phalanges of both index fingers. Brown tumors involving the distal phalanx of the left index finger and the entire right third metacarpal bone. Resorption of the tufts, especially in the thumbs. The cortex in the metacarpals and phalanges depicts fine striations. Typical findings of hyperparathyroidism. Case number 24, there is patchy demineralization most severe near the joints is quite characteristic. Rapid development of often patchy osteoporosis associated with painful soft tissue swelling following trivial trauma. Cerebrovascular disorders, cervical spondylosis, discal herniation, post-infectious states, calcific tendinitis, vasculitis, and neoplasm are other implicated conditions. Probably of neurovascular origin. Findings of reflex sympathetic dystrophy. Case number 24, shoulder hand syndrome. Deossification limited to the left shoulder, A, and hand, B, several weeks following myocardial infarction is characteristic. Case number 25, Paget's disease. The lytic phase in two different patients. Relatively well-defined V or flame-shaped areas of deossification containing strands of increased bony densities in a slightly expanded shaft are characteristic, A, proximal tibia, B, distal tibia and fibula. Case number 26, sclerotic bands are seen along the vertebral body end plates. This has been termed a Rugger Jersey spine and is characteristic for hyperparathyroidism. Note how the sclerotic bands in the Rugger Jersey spine such as this are much less distinct and fuzzier than the sclerotic bands seen in osteopetrosis. Case number 27, Paget's disease. The lytic phase in two different patients. Relatively well-defined V or flame-shaped areas of deossification containing strands of increased bony densities in a slightly expanded shaft are characteristic, A, proximal tibia, B, distal tibia and fibula. Case number 28, fibrous dysplasia. Widening of the humerus, with a ground glass appearance and a few scattered patchy sclerotic areas, is evident. Case number 29, a predominantly lytic lesion with some sclerosis and expansion is seen in the distal half of the radius in a child. A long lesion in a long bone typifies fibrous dysplasia. Although parts of this lesion indeed have a ground glass appearance, most of it does not. Expansion and bone deformity like this is commonly seen in fibrous dysplasia. Case number 30, Fibrous dysplasia. An expansile mixed lytic/sclerotic process in the proximal femur is a common pattern for fibrous dysplasia. Note that the supraacetabular region is also involved. The ipsilateral proximal femur is invariably affected when the pelvis is involved with fibrous dysplasia. Case number 31, Fibrous dysplasia. The ribs are often involved with fibrous dysplasia, as in this example. When the posterior ribs are involved, the process is often a lytic expansile lesion, whereas when the anterior ribs are involved, it is commonly a sclerotic process. Case number 31, Fibrous dysplasia. The entire pelvis and proximal femurs are diffusely involved with polyostotic fibrous dysplasia. The pelvis is severely deformed with predominantly lytic lesions. The proximal femurs are involved with both lytic and sclerotic lesions. Case number 32, Monostotic fibrous dysplasia. The proximal femur is a common place for monostotic fibrous dysplasia. This presentation is typical and should not be confused with an infection. Some speckled calcification is noted within the lesion that should not be misconstrued as chondroid calcification in an enchondroma. Case number 33, Adamantinoma. A wild-looking mixed lytic/sclerotic lesion in the tibia that resembles fibrous dysplasia is classic for an adamantinoma. This lesion occurs almost exclusively in the tibia and has some malignant potential. An adamantinoma should always be considered when a lesion resembling fibrous dysplasia is seen in the tibia. Case number 34, Monostotic fibrous dysplasia. Another example of proximal femur involvement that shows a lytic lesion with a thick sclerotic border reminiscent of a chronic infection. This is characteristic of fibrous dysplasia in the hip. No periosteal reaction.